Thank you. The advantage of being the last ones, I think most of the topics has been already covered, so we're going to test you, particularly the ones who decided to stay. So these are my disclosures, and I have received some speaker fees from Gilead in conferences outside of the country. And we will be addressing the issue of the update of the primary care guidelines, and this is an update from the March 2011 guidelines that we generated. And as I suggested, a lot of the topics were covered today, so I think we will be brief. And but before I do that, I would like to acknowledge the work of the panel members, and particularly Linda Kagi, Marianne Harris, Martin Payne, Peter Phillips, Neora Peak, Jonathan Postinoff, Ida Sadar, and also our research staff that have supported us, Stephanie Donovan and Helen Ken, and an external review panel that is still in process to validate some of our guidelines. So we'll start with some cases, and I think that's probably will illustrate better. But consider this: a 23-year-old man, college student, during a routine clinic visit to you, ordered an HIV test and with confirmed positive results. And during your initial follow-up visit, you'll learn that he is gay and occasionally uses crystal meth, multiple casual partners with unprotected anal receptive sex. So your immunization history includes all childhood vaccinations with only one MMR. So the first question, and you can vote with your clicker if you wish, is what HIV specific test will you order? CD4 counts, HIV plasma viral load and genotype, HLA B5701, all of the above, or only 1 and 2? Great, so we're ready, and I think there's about 60 people who decided to stay, which is really exciting. So the majority of you decided to order all the tests, and well, 1/4 decided only 1 and 2. And we'll explain the results. So the right answer is E, which includes CD4 and viral load, and mainly because HLA B5701 is not a specific HIV test. However, this is a tricky question because it should be used as a screening at a baseline, as it identifies people who are at risk of developing hyperactive sensitivity reactions to abacavir. But let me just emphasize that all patients entering into HIV care should have documented evidence of HIV antibody testing. It is important because what we have seen is individuals who move from out of the country or out of the province, and there's no good documentation whether they in fact are HIV positive. And in addition, there has been some scale up of point-of-care testing, and individuals might assume to be HIV positive without having appropriate confirmation tests in the past, either because they didn't show up for their confirmation or just the way that test was conducted. So baseline CD4 tests are important. Quantitative HIV RNA or plasma viral load and genotyping are of course clinical indication. I must also emphasize that nowadays the plasma viral load is a most reliable test that can guide your prognosis for HIV. So the next question is, what of the following are considered routine screening tests in HIV care? So number 1 is STIs, which includes syphilis, GC, and chlamydia screening, TB, the IGRA test, viral hepatitis A, B, and C, serology screening, anal pap smear, and only 1 and 3 are correct. Give you a few seconds. Okay, so 1 and 3, so you got it right, 89%. So certainly routine STI, TB, and viral hepatitis screening are recommended. We just heard from the previous speaker. They have switched, the BC Provincial Health Lab has switched from the RPR antibody test to the EIA, and it was being explained, so I'm not going to go again and explain about that. And just to emphasize that DST remains the standard screening test for TB. The IGRA is still not a routine test in HIV and is only indicated in a couple of groups. And if you recall, Dr. Victoria Cook was here in the previous update and also mentioned that. It's for HIV positive individuals with CD4 cell counts below 200 who have a TB skin test negative. And the other group that might benefit is also HIV positive individuals with a history of contact with active TB and who have also a TB skin test negative. So you can actually call the TB program and they'll facilitate that for you. Of course, chest x-rays are also indicated at baseline, particularly because it helps to document future changes. Toxo IgG antibodies also being indicated. Cervical pap smear for women is also indicated, which will be discussed later. Anal pap smear is not considered standard of care. It's still very much under our research, although we all know the high incidence and prevalence of anal cancers among people with HIV. Particularly, this is not the standard of care because it has not been validated. The treatment has not been validated and is not widely available access to colposcopy and treatment. So I'm just going to re-emphasize a few points about immunization, and Peter Phillips did that early this morning. So again, I'm not going to go in details. Just to remind you that we should tailor immunization to the needs of each patient. So everyone will be different. They might have different needs in terms of the vaccination. Make no assumptions about susceptibility or protection. A good history is, of course, important, and sometimes measuring some titers will also be important. Immunize at the time of maximum immune response, that's when CD4s are high. The magnitude and duration of the vaccine-induced immunity are often reduced in HIV-positive individuals, particularly at low CD4 counts. And generally speaking, avoid live vaccines unless the risk of natural infection is greater than the risk of immunization. And Peter Phillips went into details about some of those principles. So the vaccinations, to summarize, depending on hepatitis screening, hepatitis A and B vaccines, particularly with CD4s above 200. I know Dr. Phillips emphasized that hepatitis A might not be necessarily a vaccine that is indicated. However, most of the HIV positive individuals either fall into one of these two high risk categories, which is men who have sex with men, and also individuals coming from developing countries or from outside of the country where the prevalence of hepatitis A might be high. So generally speaking, in practice, it's important to provide that screening and immunization. Pneumococcal vaccination, and Peter has already explained, it should also be given regardless of CD4, and there's now a combination of vaccines, the Pneumo-C and Pneumo-P, and I'm not going to go in details because he has provided you with that. Of course, tetanus diphtheria, if not given in the previous 10 years, but wait until the CD4s are over 200. Influenza vaccination, regardless of CD4 counts, particularly because it decreases the morbidity associated with influenza vaccination. Although they might not mount a good immune response, the risk of severe complications is drastically reduced. Measles vaccination, only if it's evidence of CD4 cells over 200. And in the current context, whenever there are some exposure to measles and not being fully vaccinated, as is in this case. And HPV vaccination that can be given also regardless of CD4 counts, as per Peter advised early this morning. I would remiss not to emphasize the importance of dealing with psychosocial issues, particularly understanding that there is a significant prevalence of illicit substance use among HIV positive individuals, and this not only have implications on adherence but also on potential drug interactions, particularly when, as we discussed earlier this morning, with not only illicit drugs but also methadone and other medications that are currently used by individuals in this group. It's also important to emphasize the type of care and the need to remain patient-centered care. addressing the needs of the individual rather than the system, and dealing with stigma, isolation, marginalization, as has been already discussed, and also being illustrated early this morning, particularly with the First Nation groups, but in general, the importance of connecting these individuals to the larger system and providing them with referrals to AIDS service organizations and particularly peer support. Particularly important is also having a full involvement of youth in their own care. This is in general for the HIV positive population, but in particular for youth who not necessarily see themselves at risk or having any immediate symptoms, and therefore it's important to keep them involved and engaged in their own care. So I'm going to hand it over now to Dr. Guillemi for the second part, and hopefully we'll have a few minutes for questions.
Thank you, Rolando, and thank you for all of you to still be here to listen to us. I particularly want to acknowledge the work of Stephanie and Helen that working on the draft of this very large document. The document is not ready for release yet. As Rolando mentioned, we will have an external panel to review it, and also internally at the centers will be reviewed, and eventually, hopefully, will be released in the next couple of months or so. So in my part, and I think I'm losing the microphone, but I'll hold it. I'm going to talk about a bit of acute infection and two important new chapters, or revised chapters. One, HIV in women, that was mainly drafted by Dr. Nora Peak, and the second is HIV and Comorbidities, that was mainly drafted by Dr. Marianne Harris, so I take the credit for that. Here are my disclosures, and for a matter of time, I'll move on. So again, we have a case to start this part of the presentation. So this is a 45-year-old woman with symptoms of acute infection. She has an ELISA HIV test that is positive, but she has a Western blot test that's undetermined. And this is addressed in this document, so I'm going to ask you, what will you do? Would you like to repeat the HIV test in 4 weeks? You want to consult with PC-CDC to perform a fourth-generation AIA or a pool NAT test? Will you initiate treatment for acute infection right away, or will you reassure the patient, and since she has no significant or obvious risk factors, you will tell her not to worry about it? So please vote, and I don't remember if I had to press the button here, but I'll wait, okay. And I know it's a lot of CDC people here that will have the right answer. And yes, it is consult with BC-CDC to perform a fourth-generation test. So in our document, we'll discuss this in more detail, but essentially we say that in a case of acute infection where it is suspected a fourth-generation assay should be routinely ordered, and consult with BC-CDC is recommended to consider a pool RNA test, pool RNA NAT testing, which hopefully will give you results much sooner. With regards to consult with we also recommend that it's consulted with an HIV specialist to determine whether to initiate treatment during the acute infection and to discuss possible antiretroviral therapy. So this is not routinely indicated. So also we review a little bit about initial assessment. We recommend that patients are assessed by a primary care clinician experienced in HIV management. Primary care clinicians without expertise in HIV care should consult with a specialist or another clinician that's an expert in the management of HIV positive patients. A comprehensive medical history and a complete physical exam is also recommended upon initiation of care. And do routine monitoring visits every 3 to 6 months once individuals are engaged in care and on antiretroviral therapy. So again, with this case, your patient now had not received a pap smear for over 5 years. What would you recommend? Remember, she's a 45-year-old woman. There is no need to do a pap smear anymore. Do yearly pap smears. Do pap smear at baseline and repeat it every 6 months for 1 year. If pap smear is abnormal, then refer for a colposcopy. So, or option number 5, which is 3 and 4. So I'm sure I know it's a lot of people from our tree here, and they will get the right answer for us. So waiting for that. Right, so 3 and 4, you're right. And so the present recommendations is that pap smears should be done at initiation of care and repeat every 6 months. If the results of the pap smears are normal, then you can move on doing it annually or every 12 months. If the pap smear results are abnormal, then you have to refer the patient to get a colposcopy. Special considerations for the care of HIV-positive women, I tried to summarize in this slide, and essentially antiretroviral therapies may lower the efficacy of contraceptives. Not all of them, but I don't have time to go into detail, but essentially something you have to keep in mind and consult with your friendly pharmacist to review the interactions. IUDs can be considered as a contraceptive option. That's something that is new in the guidelines. HIV-positive girls and women from the ages of 9 to 26-year-olds should be recommended to have a HPV vaccine regardless of the CD4 counts, and I know this has been clearly addressed by Dr. Phillips and more recently by Rolando. And hormonal replacement therapy may be considered in women who experience severe menopausal symptoms, and again, expert advice is recommended in this area due to the lack of significant data in terms of drug interactions and hormonal replacement therapy, and this is new in the guidelines. Other considerations with women is the obstetric issues, and so do a pregnancy test before initiating treatment with efavirenz, so efavirenz-containing medications like a tripla, and counsel on the potential risk of risk for the fetus while on this medication. Pregnancy in HIV-positive women is considered high risk, and a consultation with an obstetrician with experience in HIV is highly recommended. So if you have patients that are planning to get pregnant, which is totally fine, please consider consulting with our experts in the OT clinic. Antiretroviral therapy should be continued in HIV-positive women after delivery, so not only treated during pregnancy, but afterwards. And breastfeeding is not recommended for HIV-positive women in Canada at the present time. So our patient now, she has a low trauma radial fracture, she smokes, and she has a low BMI at 20. So after you heard Dr. Bondi, what would you recommend? Reassure and refer to physiotherapy, perform a DEXA scan, advise to do a DEXA scan when she reaches 50 years of age, advise lifestyle changes, stop smoking and vitamin D supplementation, and 2 and 4. So by now everybody knows the answer, and I'm just waiting for it. Okay, yeah, perfect. So we are going to do both options, and I'm going to go into a little bit more detail. So in the rest of my talk, I'm going to comment about the common comorbidities, and bone disease is one of the most common, as Greg was saying. So consider risk reduction and prevention measures for bone loss, including vitamin D supplementation, and that was already addressed. DEXA scans or bone density scans are recommended in HIV-positive patients at any age if they have a fragility fracture or significant risk factors. Also in any postmenopausal women, regardless age, or men over the age of 50. So in patients with decreased bone mineral density, secondary causes should be investigated and treated appropriately, and that was, as I mentioned earlier, addressed, including referral to a specialist if you're considering treatment for bone loss or need to differentiate from, as I asked earlier, from osteomalacia to osteoporosis. Other common comorbidities in the field of HIV are cardiovascular disease, and again, assess for cardiovascular risk and all your patients, including lipid profile at baseline and 6 months later. Do an electrocardiogram on patients that are receiving PIs and rilpivirine. Both of them tend to prolong the acute T interval. That was very nicely addressed earlier today in the talks. Also, while they are receiving other medications that can influence or prolong PR and QT intervals, and methadone and other ones. Insulin resistance and diabetes mellitus also is an important issue. we recommend that you monitor fasting blood sugar and hemoglobin A1C every 6 months in all of your patients. Blood sugar abnormalities should be addressed and managed according to diabetes guidelines. Another important one is renal disease. Renal function should be monitored regularly. When there is renal dysfunction, medications, those including antiretrovirals, may need to be adjusted. Tenofovir should be avoided or replaced in patients that have renal dysfunction, and I think that's been clear now for quite a while. But also atazanavir, we have to keep that in mind. Atazanavir can cause kidney stones, and appropriate hydration is recommended, or medications may need to be switched if that's the case. Other couple of common comorbidities in our population, hypogonadism. We recommend that when symptomatic, the patient should be assessed with morning total testosterone. Consider testosterone replacement when this value is less than 10 micromoles per liter and patient is symptomatic. With regards to neurocognitive impairment, it's important to do an early initiation of antiretroviral therapy to minimize the issues related cognitive, HIV-related cognitive impairment. And all HIV-positive patients with cognitive issues should be investigated to rule out other conditions. So it's many other comorbidities that can also cause cognitive impairment and need to be assessed. Finally, lung disease is a very prominent issue in our aging population. Smoking cessation should be strongly encouraged. Patients with abnormal chest X-rays and respiratory symptoms should be referred to respiratory specialists, to the point that now in IDC we have one of them that Dr. Leon, who presented in this forum before. We're keeping her very busy with a number of patients with COPD and new findings in the lungs. Inhaled steroids should be avoided in patients receiving ritonavir, and that has been addressed before because of the increased absorption of the inhaled steroids and potential adrenal suppression. Liver disease in all patients with cirrhosis should be receive an ultrasound to rule out hepatocellular carcinoma, and this should be done approximately every 6 months, and refer to a gastroenterologist for gastroscopy and to rule out varicose veins. Esophageal veins, sorry. So a screen for non-HIV related carcinomas is also recommended. There will be a table in this document that will address each one of the different cancers and a way to screening, but generally we will recommend that you refer to the Canadian guidelines and other guidelines with regards to that. So that's pretty much in terms of the guidelines. I don't have much time to go in my next 3 slides because I would like to give you a chance to do questions, but it's essentially referred to an upcoming online course that we're still working, and we will let you know more probably in the next update about this interprofessional online course. So I'm going to stop here and consider any questions. Thank you.